recording. Someone's dog wants to join the Zoom. My cat always does, but actually she's watching the squirrels outside play in the yard, so maybe she won't join us this time. All right, like I said, we're going to start with seizures. So let me share my screen with you and pull up that PowerPoint. Okay. So, seizures are probably one of the more scary things that your patient can experience, not only for them, but for you as a nurse. It's extremely violent at times with the movements that they do, and it's extremely scary for families. It's extremely scary for you as the nurse if you've never seen one. However, there are certain things that you do to keep that patient safe and to protect them from injury and to make sure that you observe what's happening so that you can document it so that the physician or healthcare provider knows exactly what happened with that patient. Now, what is a seizure? By definition, it's abnormal, sudden, excessive, uncontrolled electrical discharges of neurons in the brain, and it can result in an alteration of consciousness. It also may not. It can result in motor or sensory ability. It can also result in changes in behavior. Okay, so basically what you see is that uncontrolled electrical discharge, that rapid firing of those neurons is what causes either that alteration in consciousness or motor or sensory alterations. Now, typically what you see is that seizures start in one area of the brain, and they can just stay in that one area, or it can spread to other areas, and it can spread to the entire brain so that the entire brain is experiencing seizure activity. Now, one of the things you need to remember is that about 5% of our clients with head injury will develop seizure disorders. They're basically classified as two types: primary or idiopathic, meaning we have no clue what causes them. They also can be considered secondary, and that typically results from metabolic disorders like hypoglycemia or acute alcohol withdrawal, electrolyte imbalances, cardiovascular disease like stroke, or aneurysm rupture. It can occur from anoxia, like low oxygen situations, like cardiac arrest. Seizures can also occur because of infection or high fever, exposure to toxins, particularly things like pesticides that are neurotoxins, trauma like head injury or concussion, tumors, brain stem or spinal cord, and it can also result from vascular abnormalities like aneurysms or arterial venous malformations that occur in the brain. Okay. these are some of the causes of what we consider non-epileptic seizures, or these are seizures with a metabolic cause. Hypo or hypernatremia, okay? What is your normal sodium level?
135 to 145.
135 to 145. I start worrying about patients with seizure activity when it gets below 130. Okay. When it's in the 120s, I'm extremely concerned about the possibility of seizures with those patients with hyponatremia. Now, with hypernatremia, I am very concerned at 150 and above, okay? Because the body just does not tolerate being too far out of that range. Hypoglycemia is one of those things that's sort of individualized, guys. I mean, I have seen people experience hypoglycemic seizures with a 60. And then I have seen other patients that did not seize until they were in the 20s. So it will depend on your patient. Now, non-ketotic hyperglycemia, remember, is sort of that HHNKS syndrome, where you get a syndrome with a very, very high blood sugar. We're talking maybe 800 to 1,000. But these patients don't have a ketosis with that. They don't spill ketones. Hypocalcemia and hypomagnesemia, or magnesium levels or low calcium levels, can also cause seizures, because calcium and magnesium are necessary for muscle movement. Hypoparathyroidism or hyperthyroidism can be a cause of seizures. Adrenal insufficiency, like our patients with Addison's disease, where their adrenal glands do not produce enough cortisol or cortisone, or those adrenal corticoids. Those patients can get very ill and suffer seizures if we don't supplement them with an exogenous steroid. Now, what the majority of patients that you probably are going to see nowadays may be due to drug intoxication or alcohol withdrawal, okay? Those patients with those overdoses or withdrawal can suffer seizures. Now, that's being said, if a patient has a seizure from alcohol withdrawal or has more than one because they've had more than one episode, that does not make them epileptic, okay? They do not have epilepsy. Even though we treat seizures from these causes similarly to what we do with epileptic type seizures for emergency care, patients that have seizures from these causes do not need to go on anticonvulsant medication. We just need to maintain their sodium or their sugar in that normal range, and hopefully they will not have seizures again. Now, what is epilepsy? You know, I talked about metabolic seizures. Well, epilepsy by strict definition is a chronic neurological condition that's characterized by recurrent seizures of non-metabolic causes. Typically, it's 2 or more, what they're talking about with recurrent. One of the things that you'll see is, as it says, it's the most common serious brain disorder worldwide. It basically has no age, racial, social class, national, or geographic boundaries. Now, one of the things we treat people with if epilepsy is medication, but more than a third of those that are treated continue to have seizures, even on the medication to control it. Now, febrile seizures, before we talk about true epilepsy, they're sort of a different type. They're non-metabolic, but it's something that we see in children, okay? And sometimes what happens is that, quote unquote, these children grow out of them, okay? Meaning that they don't have seizures as an adult or as an older child. But a lot of these children do go on to develop temporal lobe epilepsy, which we'll talk about in a little bit. Febrile seizures occur in children as a result of a rapid temperature rise above 102 Fahrenheit, or if you're using centigrade scale, 39 degrees. As a general rule, they're usually seen between the ages of 3 months and 5 years of age. Typically, after 5 years of age, we don't see them as frequently. The peak incidence is between 17 and 24 months of age. Now think about that. You've got this tiny little baby or a toddler, and they start having a seizure. How freaked out are these parents going to be?
Very scared.
Very scared, highly emotional. And, you sort of wonder, they wonder, is this something my child's going to have to live with? Well, one of the things that you'll see is that febrile seizures usually occur on that first day of fever or illness, okay? And after that first rapid rise, the majority of these children do not continue to have seizures throughout that illness period, okay? So what do we see with these children? They get what we call generalized tonic-clonic seizures. And those are the worst looking ones, okay? Meaning that the entire body has these jerks and they have a rhythmic movement where this child is unresponsive. And it's due to that rapid rise in temperature. Now, one of the things that you need to think about is this. Children with febrile seizures often have a family history. So if one of their older siblings had a febrile seizures, the other siblings are likely to have them as well. If mom or dad had febrile seizures as a child, their children are likely to have them as well. Children that have febrile seizures have a 30 to 50% greater chance of experiencing a future seizure. which means that with every illness that they have that rapid rise in temperature between the age of 3 months and 5 years, that they may have another febrile seizure. As I said, about 95% of these children do not develop epilepsy. As a general rule, treatment is not recommended with anticonvulsants. What they will recommend is antipyretics for these children during illnesses with temperature rises. What we're trying to do with that, either ibuprofen or acetaminophen, is to slow that rapid rise in temperature. It does not stop it, but maybe if you can decrease the rapidity of that rise, you can decrease the severity of that seizure. Okay, before we start with the rest of it, any questions about febrile seizures?
Are they just from the child having an extreme, like, high fever? Like, is there any other causes that would make them have those kind of seizures?
No, there are no other causes. It's that rapid rise in temp.
Okay, thank you.
And that genetic, the family history or that genetic predisposition to having it. My cat did decide to join us here. But they're not considered epilepsy, but they're not considered a metabolic cause either. Okay. Like I said, the majority of these children, 95% of them don't go on to develop any type of future seizures after the age of 5. So one of the things that you'll see is that, you know, if someone said, well, I used to have seizures, but I grew out of them, okay, this febrile seizures may be what they're talking about.
Something causes the fever though, right? Like if they're just not having a
Yeah,
random
a lot of it is viral illness. And you know how kids in daycare get, Lord help you. From 3 months to 5 years, I mean, colds and flu and the Lord knows whatever else. But anytime they have one of these viral illnesses or bacterial illnesses that causes that rapid rise in temp, they are, you know, often will have seizures.
And is there like maybe a time that maybe the parent will see it, like first thing in the morning when the kid wake up, or it just happens?
It just happens.
Okay.
Okay. And it's one of those things that, yeah, you know, well, when is our temperature at peak?
True.
Most of the time it's in the early afternoon.
Yeah.
Because of our circadian rhythms, if you think about it.
Okay.
So that may be one of the, you know, the areas where you sort of worry about. Our normal body temperature is higher in early afternoon. So if they have a viral illness or bacterial illness on top of that, then you may see them experience seizures then. Okay. Any other questions about febrile seizures?
I have a question. If you have a child who is already epileptic, do they have a greater chance of having seizure incidences with a fever?
No, unless there's a family history of febrile seizures. No. This is one of those things that's sort of separate from the epilepsy. But children that have a seizure disorder are no more likely to have febrile seizures than someone that does not have that family history.
Okay, thank you.
Mm-hmm. All right, so now let's talk about some of the different types of seizures that you may see. When you're talking about seizures, they classify them as partial or generalized. And partial seizures basically involve one area of the brain. And a lot of times it does not impair consciousness. Okay. Now, you can have complex partial seizures that secondarily generalize, and they will have a loss of consciousness. But as a general rule, partial seizures, those patients will have appear not to lose consciousness. Okay. So simple partial, complex partial seizures are the partial type. Generalized seizures usually include a loss of consciousness because the entire brain is involved. Now, there are several types of those. Absence, okay, it's the French pronunciation, absence seizures, myoclonic seizures, tonic-clonic seizures, which is the big bad one, and then atonic seizures are also generalized seizures. Simple partial seizures are usually confined to one area of the brain. Those patients remain conscious. They may report what we call an aura, okay? And with this, I'm not talking about they don't glow. They don't have that high pro glow, so to speak. But an aura in this case is a sensation that's different than their normal. Some people report a smell. Some people report a taste. Some people report that funny feeling in the pit of their stomach. Some people report tingling. Okay. An aura in this case is a signal that they may be going to experience a seizure. It's a warning sign. And typically what we teach patients is once you recognize it, then sit down, get yourself somewhere safe. Even though these seizures are not extremely violent with the jerks, they do need to be in a safe place. Typically, these patients will also experience tachycardia, hypotension, or hypertension, either one. Their face may be flushed or their skin may be flushed because of increased blood flow. They may have what we call a sense of déjà vu. And déjà vu basically means having seen before or been there, done that. Something that they feel that they've already experienced. I've already done this. Why is this happening again? Some patients experience anger or fear, and that will depend on the part of the brain that the seizure is originating in, especially if it originates in the limbic system, which is where our anger and fear centers are. With simple partial seizures, there's no alteration in the level of consciousness. And often that patient may be able to talk to you during that seizure. A lot of times what you see is tonic contractions. Tonic means tightening. Clonic means jerks. So basically you may see a contraction of the face, fingers, feet, and it will march up the muscle group on that same side of the body. So if it begins in the fingers, you may see movement, and then it will move up the arm so that the entire arm may be involved, and then it will end very similarly. The last place that the jerking will stop will be in the fingers where it started. Simple partial seizures may have autonomic sensory, motor, or psychic functions, meaning that what you see is that anger, that fear, or those abnormal sensations. Okay? Complex partial seizures. These usually originate in the temporal lobe, okay, of the brain. And they are fairly often classified as having what we call autonomisms, which are repetitive movements like lip smacking, head rolling, swallowing, arm or leg movement. These can be preceded by an aura, that unusual smell, or intense emotions. They can have decreased consciousness, meaning that they are not able to respond to you during the seizure. And they may have that up to several hours in what we call the post-ictal state. Ictus is a Greek word meaning seizure. So post-ictal means after seizure. Typically, they will not remember the seizure. They have amnesia of that event. Temporal lobe epilepsy is going to account for about 70% of complex partial seizures. Some of these patients do have a history of febrile seizures as a child. The 5% that do go on to develop seizures, usually it's these complex partial seizures. A lot of people that have head trauma may have complex partial seizures if the damage was done in that temporal area. Auras are very common. And a lot of times what you will see is they have a feeling of tiredness or lethargy before that seizure. Okay, so let me stop sharing that and see if I can pull up some examples for you guys. Okay, so let me share with you and show you the difference between simple partial seizures and complex partial seizures. Okay, so let me try to do this, and if it works, great. If it doesn't, I have these posted so that you can take a look at them. Can you see the little baby on the screen?
Yes.
Okay, so this is an example of a simple partial seizure.
Hey, Benji, you gotta stand back, okay?
Okay, watch his hand here.
His leg is shaking too, but he's definitely awake. Okay, it's okay. It's okay. It's okay. It's okay. It's okay. It's okay. 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 Okay.
And see, he's able to move that left arm with no problem, but that right arm has that shake.
It's okay. It's okay. It's all right. It's okay. It's okay. Now he's like twitching. Yeah. It's okay. Hey, we'll call you back. He's having another seizure. Okay. Okay. It's okay. It's okay. It's okay. And his arm's like extended. Are you doing this too? Yeah, stop. Not yet. What's this?
Okay, that was a simple partial seizure. Remember, the child did not lose consciousness, but had that shaking on the one side of the body. Sometimes it's one arm, sometimes it can be the entire side. Now, this gentleman has a complex partial seizure, which again, like I said, is the autonomisms, that lip smacking, that repetitive motion, okay? But watch John as he has this complex partial seizure. Now, the reason that he has this cameraman in his house is that they are, in fact, doing a documentary on complex partial seizures. And eventually this gentleman goes on and has seizure surgery to remove his seizure focus. So watch John and the difference between the two. Okay, see, he's starting to move his lips.
No, this is going to be very weird. Why? Because he has, look.
See?
Look. We're going to send it to Dr. Filmic, $900. Oh, what do you see? What is it? What do you see, babe?
See, he's not responsive to her.
Who's that? Okay, so this would be complex partial.
For the virus, August 22nd, 2009 at 3:14.
What? What do you see? Look. What is it, baby? What do you see, honey? Hey, look at me. Babe, look at me.
He's out of the seizure.
Hi. How are you? You're gonna wait a minute. Sit down. Wait. Slowly.
Let's all go.
Probably can be.
Okay, so that is an example of a complex partial. And if you really didn't know what you were looking at, you thought he would be just sort of strange acting. With some complex partial seizures, with patients that I've worked with, sometimes you think that the lip movement and things that they have, are similar to what you see and sometimes with your patients with tardive dyskinesia from some of the psych meds. Same types of things. I've seen chewing. I've seen the lip smacking. I've seen people sticking out their tongue. We had one gentleman that came in and repetitively washed his hands. And I thought he had OCD or obsessive compulsive disorder. But it wasn't until we had him hooked up to the monitoring that we recognized that that was his particular seizure activity. Okay. Complex partial seizures don't look like the nasty seizures that you see on TV or Grey's Anatomy or things like that, but they can become that. Okay. Complex partial seizures can what we call secondarily generalize, meaning that they can go into that tonic clonic movement and lose consciousness. Okay. Questions on either simple partial or complex partial seizures? Okay, let's go back to the PowerPoint.
Miss Hyde, I sent you a message in the chat, but I can just read it to you if you want.
That's fine.
So the baby video that you showed us, would that also be a febrile seizure or?
No.
Okay.
That would not, because the febrile seizures basically are the tonic clonics. They are the really bad ones. Okay.
So you're not going to see something like simple or complex?
No, you will not. You see tonic clonic seizures.
Okay, thank you.
Okay, so with the next type, absence seizures. Basically, sudden brief cessation of motor activity, and it does involve both hemispheres. These children often have, and it is very common in children, they have a blank stare. They're unresponsive when you call their name. It does tend to run in families, and it can be very, very brief. Usually it lasts only 5 to 30 seconds. A lot of these children that may be having absence seizures are accused of daydreaming or may be misdiagnosed. They think the child has ADHD, daydreaming, or just not paying attention in class. One of the things that you'll see is that sometimes it's very difficult to do well in school when you're losing 5 to 10 seconds every few minutes. Now, this is a generalized seizure, so often you do not see an aura or a prodrome of that lethargy. Okay? There's no warning. It's sudden interruption of consciousness. You may see staring and what we call 3 hertz blinking. Okay? Sometimes they can do some of these autonomisms, but not often. With children or adults that experience absence seizures, there's no postictal confusion. They don't even know that they had a seizure. Typically, this type of seizure starts between ages 4 and 10 years of age, and likely is to resolve by age 20. Okay. So now let's look at an absence seizure. And this is a young child that's sitting there doing his homework. So just take a look. Seizure. And see, he goes right back into doing his work.
Even though you're absent, she sent me the homework that when I was absent.
Seizure. And he's out of it. Okay. See how that would be misconstrued as not paying attention? or daydreaming. Okay.
Miss Hyde, I have a question.
Uh-huh.
Is there like a reason that happens? Like, is there something that kind of causes it to happen at a certain time, or is it just something that randomly happens?
It just randomly happens.
Okay.
Like absence seizures are one of those idiopathic. And idiopathic means that the idiots can't figure out why it occurs. Okay.
Okay.
It basically means we don't know. And it may be that there is, since it is familial, there may be a genetic component to it that may have environmental influence. We just don't know. But, you know, with these children and young adults, think about their schoolwork significantly impacted because they're losing that time every time they have one of those seizures. You know, one of the things that has to be done with these children is, if they do have this history of seizures, is to let the teacher know that is occurring. And of course, you know, you don't want to freak out the teacher, but you want them to know that this child is not just not paying attention, but this is a medical problem that they have that they can't help. So
I have another question for you.
Uh-huh.
So like with these happening all the way to like up to the age of 20, what about the teenagers that like go to get a driver's license? Do they have to like hold off and not get their driver's license?
And we'll talk about that.
Okay.
Yeah. The rule in North Carolina is you have to be seizure free for 6 months in order to drive. So as long as they're having these seizures, they are not allowed to get a driver's license.
Okay. I was just curious.
Yeah. All right. So back to the PowerPoint. All right. So that was absence seizures. The next one we're going to look at is tonic-clonic seizures. In the old terminology, these used to be called grand mal seizures. Okay. It's a French term that means big bad. And that's basically what they are. Tonic-clonic seizures are the most common type that we see in adults. These patients often will have an aura, that unusual sensation or that sense of uneasiness prior to the seizure. A lot of times they will have a sudden loss of consciousness. And there are a couple of phases. The tonic phase, that's where they are unconscious and they will have what we call a continuous muscle contraction. So that what happens is they stiffen. And typically what happens is that muscle contraction often forces the air out of the lungs over the vocal cords, causing the patient to either make a sound or cry out. A lot of times it's a type thing. That tonic phase usually only lasts about 10 to 15 seconds. And then they go into what we call the clonic phase. And that's alternating muscle contraction and relaxation. Now, as a general rule, that lasts about 1 to 2 minutes. It can occur longer, but we get very concerned about it if it lasts up to 5 minutes. And we'll talk about that in just a few minutes. The third phase is what we call post-ictal. It follows the seizure activity. There's usually a decreased level of consciousness, and this person just wants to sleep. Sometimes this post-ictal phase will last for a few minutes to several hours. The majority of the times, these patients will have confusion. They'll be very sleepy and very agitated if you try to wake them. It's a recovery period. One thing that you need to remember during this type of seizure, the metabolic rate increases about 400% during the seizure. So our glucose and oxygen supply in the brain is pretty much depleted the longer that seizure lasts. Now, one of the things that you probably remember from CPR is that our brain basically has like 4 minutes worth of oxygen if we stop breathing. But if I raise my metabolic rate for 4 times normal, that means that my glucose supply, which is what the brain uses for energy, and my oxygen supply, which is what the brain uses to maintain perfusion, is depleted in about a minute. So these patients need that recovery period in order to regain and allow that brain to heal from that deprivation. Okay? All right, so now let's look at a tonic-clonic seizure. Now, one of the things I'll tell you guys is that this gentleman is in an epilepsy monitoring unit. He does have electrodes, EEG electrodes attached to his head. He does have a video camera on him, okay? And a lot of times whenever we're doing evaluation of seizures, that's what we do. We put them on 24, 48, 72-hour monitoring with a video camera and electrodes in order to capture the seizure. It allows the neurologist or the epileptologist to figure out exactly where in the brain that seizure is occurring. Okay, so now let's watch this seizure. I mean, you see he's just coloring. Starting to have the seizure.
It makes all kinds of other designs.
And you can see the jerking. Now, I don't recommend nasal cannula. Face mask is better because trying to hit that moving target, But she's basically just giving him an oxygen source.
He does, okay.
And you can see the seizure is calming down.
So is this the clonic phase now?
This is no, actually he's starting to move into the post-ictal phase.
Okay.
The tonic phase is whenever he's stiffened. The clonic phase was the jerking, and now post-ictal. And you can see that he is fairly sleepy right now. Okay. So what you will find is that this type of seizure is the really scary one that most people think about for seizures disorders, but it's not the only type that we have. Now, there are two others that I included on your list, but I didn't include on your PowerPoint. This is a myoclonic seizure, okay? And this is a 16-month-old that has some unusual movement that is what we call myoclonus, or the jerking, okay? Now watch this child. And see how he's doing that jerky movement. That's called myoclonic seizures.
I don't know if it's a seizure or not.
What?
It's the first time I've seen this.
Now this child has another type of seizures as well, but this is the first time this mom has seen this type.
It's been going on for about 2 minutes.
What? Okay, that one.
No, that's for Daddy.
What, you're making
Chase, are you all right, buddy? Chase, where's Mama?
You see, not responsive.
It's Mama. Mama. Look what I made. I made a move. I made a shape.
You sure did.
Now he's out of the
Is that better,
seizure.
Chase?
Yeah.
You done? No.
Okay. But see that jerky movement? That is called myoclonic seizure. Now, this little girl has what we call atonic or drop seizures. Now, where this little baby, the 16-month-old, had those jerks and a stiffening or tightening of the muscles, this little girl basically loses muscle control and her muscles completely relax. So watch what happens with Sienna. Seizure? Seizure? So you can see that sometimes, you know, these seizures can appear much different than what a lot of people think about. Sienna had the drop attacks. Basically, she would have the head movement. There used to be a video of this little boy that was eating, and he basically just hits his head, I mean, with a horrendous smack on the table. And I'm sure YouTube probably took it off because of inappropriateness, but it was a great example. One of the things that you will see with these patients with atonic seizures is they're at great risk for injury. Okay. She had on a head wrap. The majority of these patients that have atonic seizures need to wear helmets because of the probability of injury to their head. If they are in a standing position, I've seen these patients fall flat on their face or either forward or backward. And it can be very, very damaging and risky for them. Okay. So risk for injury, high priority for our patients with seizure activity. Okay. So I tell you what, it's 3:56. I'm going to stop it here. I will open up those videos so that you can watch them again and watch some of that activity. And then we will start, I guess, next Monday with the status epilepticus slide. Okay.
Quick question, Ms. Hyde, before we go.
Sure.
As far as them other two seizures go, from what you just told us, for testing purposes, do we just need to know the ones you went into detail with in the PowerPoint?
I would suggest that those are probably the ones that I would focus on more.
Okay.
But I just wanted you to be able to see the other two.
Okay, thank you.
Okay. All right. Any other questions? All right. I will see you guys on Monday, and I will post this recording as soon as it gets converted, okay?
All right, thank you.
Thank you.
All right, y'all have a good clinical week and weekend if you're off.
Thank you.